Pulse pressure. When we measure blood pressure live, so to speak, in a vessel, which vessel we're measuring will determine the waveform, right? So if we happen to have a fancy catheter into the big vessels in the chest, well, then we can get a line that shows us the aortic pressure, right? Systole, diastole, systole, diastole. And here is that dicrotic notch, or the incisura, which is from the aortic valve closing. It causes this little sort of pressure bump. As far as I know, it has no clinical relevance. Does anybody know of any clinical relevance to the incisura? Yeah, me neither. But it does make that funny looking picture. All right, so then if we go further down and we measure in the femoral artery, we see that the pattern is generally the same, right? We still get a systole. We still have a diastole curve, but we have this little divot here. That's actually from that same dicrotic notch. So instead of having a nice smooth curve down, we get this little bump. But that's the pattern that we see. In the radial artery, again, pattern still the same, but the curve is getting smaller. Arterial, smaller yet. Capillary, almost flat. All right, so big picture, what's happening? We're losing our pulse pressure, right? Pulse pressure is the difference between systolic and diastolic. That's your oomph, your pulse pressure, your wave front that the heart is making. The further out in the vessel system we go, the less of a big pulse wave we see. All the way until we get to the capillaries, where we see almost no pulsatile flow. It's pretty much flat. Why? Well, we've got two things that are eating away at the pulse pressure, the big up and down. The first is resistance. As the blood travels through the system, it's always losing energy, right? Because of friction and having to push the other blood out of the way. So as it loses energy, it loses pressure. So by the time you get to the distal radial artery, the pulse pressure is much less because it's been used up by resistance. The other thing that uses up pressure is compliance again. So if you think about our balloon example, okay, a balloon has a tendency to absorb pressure because as you put pressure in, that pressure becomes volume change, right? So just like compliance causes vessels to expand, it also causes them to sort of absorb pressure in deformation and then return it in elasticity. So those are both explanations for why we have a big pulse pressure in the big arteries, but not much of a pulse pressure in the arterioles and the capillaries. Right? Now, in terms of our functioning physiology, it's good that we don't have a lot of pulsatile flow in the arteries and capillaries because it means that we have a nice smooth flow. We don't have blood that's starting and stopping like we kind of do in the femoral artery. By the time it gets to the capillaries, it's just trickling through in a fairly constant way. So